Good morning and welcome to Understanding and Managing the Psychological Impact of Blood Clots webinar. I'm Jo Jerome, Chief Executive Officer of Thrombosis UK. And today we welcome almost 300 registered attendees from more than 26 countries to this webinar. Some of today's attendees will have joined our previous webinars, and it's thanks to you and your positive feedback and suggestions that we're able to host today's topic. This morning I'm also delighted to welcome three leading experts in this field. Our chair, Professor Simon Noble, is a Marie Curie Professor of Supportive and Palliative Medicine at Cardiff University and Honorary Consultant at the Royal Gwent Hospital, Newport. Professor Noble is a trustee and medical lead for Thrombosis UK. He has extensive research interests and published papers and books. A few of you may also know he's a talented rapper, but I am sure for all of us, we know Professor Noble for the tremendous difference he has brought to awareness and understanding of blood clots, in particular cancer-associated thrombosis. We're also delighted to welcome Dr. Rachael Hunter, who is a chartered clinical psychologist at Swansea University. Dr. Hunter has published many research papers and continues to be involved with a range of research exploring how people understand and respond to illness and live with chronic conditions. Presenting with Dr. Hunter is Professor Paul Bennett, a clinical health psychologist, also based at Swansea University. Professor Bennett has worked as a clinical psychologist in the NHS and an academic. He is author and co-author of 5 books and over 120 publications. Very importantly for today, all are passionate advocates for the psychological impact of blood clots, and over the past 5 to 6 years have undertaken clinical research on the impact and how people cope with venous thromboembolism. Subsequently, this is being published in a number of psychological and medical journals and is now cited in national and international guidelines. So without further ado, I'm honoured to hand over to our chair, Professor Simon Noble, to begin today's webinar. Thank you.
Understanding and managing the psychological impact of blood clots. So I think, first technical issue. There we go. Right. I think one of the questions that I think is really important is why, as psychologists and clinical psychologists, we actually got involved in this sort of area. And I think that the figures in this first slide really show why. And I think where we come from is the idea that the problems of dealing with the thrombosis and all the emotional sequelae are actually normal reactions to an abnormal episode, an abnormal incident, an abnormal health problem. So the figures are not, oh, people are really struggling psychologically because they're not capable of coping. The figures are as they are because these are the natural sequelae of what can be a very frightening incident or frightening and long-term consequences. And just to give you some idea of the scope of that, these are some data that we gathered following a group of people through a UK healthcare provision looking after people that had had thrombosis from various causes. And we measured psychological consequences a month and then 6 months later. And the numbers you've got here are the percentage of people that would experience significant problems as a result of that. So if you look down, we've got anxiety. Now my dog's decided to bark, apologies. We've got anxiety and depression, and these are clinical levels of these conditions. So they are not just a mild issue, but these are people that are really struggling. We've got PTSD, which is post-traumatic stress disorder, and we've divided that into 2 levels. Clinically relevant is where people are experiencing problems that are sufficient to interfere with their daily life. And clinical diagnosis is where people will be given a diagnosis of PTSD, post-traumatic stress disorder, if they were to see an expert. And then health anxiety, again, this is a technical thing. It's not just people that were a bit anxious. These are people that will be defined as being clinically health anxious. And I think, I don't want to go through all the numbers, but critically, there's 2 issues. First of all, almost, half the people that had some sort of thrombosis are experiencing health anxiety 6 months on. And the second interesting thing, I think, and I can say interesting for people experiencing it's not so much interesting as problematic, is that what you would normally expect is people that have gone through some sort of trauma to hello Simon, to gradually recover. But the rather depressing news for us is that 6 months on, if you look at just about every single measure there is no improvement. People are continuing to have problems for quite a period after time. So I'll hand over to Rachael now, who can tell you a little bit more about the nature of these problems that they're facing.
Thanks,
Just
Paul.
make sure she's listening.
I was waiting for the slide, yeah. So as Paul said, we set out on a large research project looking at gathering some of those measures that Paul's just talked through. And the other part of that project was really important to me, was to hear directly from patients, from people who'd survived thrombosis, who'd experienced DVTs and PEs. And so I spent quite a long time going around Wales in particular, but interviewing people in great detail really about their experiences of having a PE or a DVT. I spent a lot of time with people, gathered some really, really interesting stories from them. And then with all of that data, there was a huge amount of data because I went back to these people 6 months later to find out again, you know, how are you coping, how are you adjusting, how has this impacted you? And when we had all that data, we looked at it in real detail and we analysed it for what themes were kind of shared between people. So what we started to see were some things that lots and lots of people were reporting. And this is where the kind of term post-thrombotic panic syndrome come from. And this came directly, this phrase that was directly mentioned by one of the interview participants, you know, who knows he might be listening today. That would be a great sense of full circle. But you know, this, what we describe as, what he described as post-thrombotic panic syndrome, is described by lots of patients actually. It was a sense of this kind of being on high alert and being super vigilant and super tuned in to the physical sensations that, you know, that were associated with their previous BTE or previous thrombosis. So things like they were starting to report, you know, feeling panicky, having a sense of being on edge, a lot of the time being alert to physical triggers, for example. So it was widely reported, and it's when we took that back, interestingly, to clinicians, and I talked about that with people like Simon, what they told us was that, yeah, this is what people are saying. This is what people are saying in my consultation room. This is what they're describing. This is what I wanted to do the research. So that was the other strong theme that...
Rachael, could I just interrupt a minute? The sound quality is bad, and apparently it may improve if your speaker is turned off. Are you able to try that and see if that improves things?
It's turned off. Okay.
Yeah, you turn your speaker off because there may be some feedback.
I haven't got a speaker
Turn
to
your volume
turn off. Is that better?
That sounds better to me, I think. We'll try that. Thank you, everyone, for pointing that out, and hopefully that will be better. Cheers.
All right, then. Can you give me a thumbs up if it's going, if that seems better? Okay. So I was just mentioning, I'll just quickly recap post-thrombotic panic syndrome for those who didn't hear that. This was really widely reported among all the interviews that I did with the 12 people at 2 different time points. And this was the sense of anxiety and worry that these reoccur. So what was happening was they were super alert to sensations and feelings that were reminiscent of their DE. The strong theme is that people, I'm getting a lot of messages that mine isn't working, so I'm wondering if, does Paul want to pick up if it's bad sound quality?
Yeah, we've spoken many times, Rachel, and we've never had this problem, so it's a bit strange.
Okay, Paul, do you want to carry on here, and I'll see if I
can do that.
Yeah,
that's fine. So sorry, folks, you got me instead of Rachel, which is a bit disappointing, but there we go. So as Rachel was saying, well, in her interviews, what we identified was 3 different separate types of problems people were experiencing, and the first is exactly that. The labels that we have in the slide look very technical: post-thrombotic panic syndrome and neurosis, but those actually came from the people that Rachael was talking to. So the first of those was something the person called post-thrombotic panic syndrome, which is a very acute, short-term episode of high-intensity anxiety. I'm sure we're all familiar with the notion of panic, so I won't dwell on that, but we'll come back to each of these in a bit more detail in a minute. The second thing they identified was, again, what one of the participants called post-thrombotic neurosis, which is just that longer-term, intrusive, nagging worry. You know, every time something happens, you think about the consequences. So it doesn't cause a panic, but it's still very debilitating, still dragging people down. And then the third thing, which is rarer, but nevertheless what some people talked about, was what technically is post-traumatic stress syndrome, which is essentially, I suppose, defined in a number of ways. But as Rachael was saying, this high vigilance, you're always on edge. And there's flashbacks, which are technically memories of the event itself, that come to mind unwanted and can be quite scary because it feels like you're there at the time, and that's pretty difficult to deal with. So those are the 3 different types of issues that we identified. Sorry, my thing's not working. I'm going to scroll through slowly if I can. So what I'll talk about is each of those different issues in a bit more detail, with some of the strategies that people may find useful to deal with those. And if Rachael wants to interrupt and the electronics start working, that's fine by me. So post-thrombotic panic syndrome. As I say, it's this high level of acute anxiety triggered by memories of the event, things that were associated with the event. One of the things that we put here was that one of the things that can trigger this, which is something that often medics say to try and reassure, was, you're lucky, you could have died, we saved your lives. And those things go flashing through people's minds and can cause significant problems. And the other things that can trigger them are sensations that match the original symptoms. And that's what I really want to talk about now. And I remember I was talking to somebody about this, and they were talking about their panic. And they were saying, you know, if they walk along with their mobile phone, they can get very out of breath, and that can trigger all sorts of anxieties and so forth. So it can be the most trivial things that can set off this panic. And there is a well-known process in psychology known as the panic cycle. And what this involves is, if people can see on the left-hand side, you have something what we've called a trigger stimulus. And that is something as simple as walking up a flight of stairs and becoming a little bit breathless, a little bit out of breath. Now, if I walk up a flight of stairs, which I often do, and feel out of breath, I just think, Paul, you're getting old and you're getting slow. But if somebody's had those symptoms, those sensations at a time of high anxiety when they were having particularly a pulmonary embolism, but it can be associated with other things, what it can do is immediately put you on the alert. Rather than those sort of neutral words that I have, it's, oh, we have a problem, something's going on. And then what typically happens is that the person then focuses inwards. They then look for signs and symptoms. And of course, that makes them anxious. And part of the process of anxiety is you start breathing a little bit more, you start feeling a little bit tense, you start maybe even feeling a little bit dizzy or whatever. And then you start thinking, wow, I really do have a problem. Things are really going wrong. and you get into a cycle where some benign and actually quite normal sensations trigger an anxiety response that eventually ends in the person hyperventilating, overbreathing, with a whole bunch of sensations that go along with that, feeling dizzy, feeling short of breath, and literally feeling panicky. So there's that flow. So if you look at the circle, you've got perceived threat, then you've got apprehension, then you've got the bodily sensations, the interpretations as in the beautiful psychological term catastrophic, and then you get a cycle going. So as I say, benign sensations lead to that immediate sensation of panic. And it's not the sensations that are the issue, it is that, that initial interpretation of, oh my God, is this another PE? Am I having another problem? So if you're trying to treat, if you're trying to manage that panic process, there are a number of points of intervention that you can do. And the first one is really just being aware of risky situations for you. If you're walking up a flight of stairs and you know that's likely to trigger sensations, just remind yourself, well, hey, if I get some sensations, it's probably because I'm just doing something too effortful that's going to cause me those sensations. Secondly, if you get sensations that are reminding you of that, well, remind yourself that a lot of people get these. It's just that, you know, these are sensations that we all experience, and they are not necessarily the sign of a crisis, of a health problem. They are the sign of you're slightly out of breath because you've been doing X, Y, and Z. So you can begin to reassure yourself and remind yourself that, you know, this is not a recurrence. The breathing is at the middle of all this. If you start over breathing, then that triggers this whole sort of process. So one of my colleagues used to have this very simple process that she called counting the square. And that is all about getting your breathing under control. So what she suggested is she had this image of a square in your head, and you walk along the square. And as you walk along the square, you breathe in and you count to 4. So it's breathe in, 2, 3, 4, hold breath, 2, 3, 4, breathe out, 2, 3, 4, hold that out, 2, 3, 4. So it's a way of bringing down that rapid breathing that's driving this whole process. It's simple, but you don't want to be doing anything complicated at this time. So a simple breathing exercise can help. If you're feeling more adventurous and you've gained the skills, then you can learn to physically relax the entire body, the arms, the legs, the whole, the gut that's probably very tense and so forth, so you can breathe down. If you're reading the slide, you'll see something about a brown paper bag. Well, that's a little bit of a joke. In the old days, they used to say, breathe into a solid brown paper bag. And I can explain why if people are interested. But yeah, you don't want to be carrying a brown paper bag with you, that's for sure. But the critical thing is, it is interrupting that flow. It is reminding yourself that the sensations are normal. It is doing those very simple breathing exercises. And you can always think, well, if I do these for 5 or 10 minutes and things don't improve, then that may be a time to seek help. It may be time to talk to people, etc. But give yourself those 5 or 10 minutes to sort of utilize these strategies before assuming that there is a crisis. It's a very simple thing to manage. Rachel, are you talking now? Are you talkative? Is there anything to add here?
I can try. Is that any better? Is that any better for sound?
Clearer but quiet.
Okay, let me try. If it's clearer, if I put the sound up a bit, I'll keep talking. How's that? Is that better? Yeah, I'm getting a few nods. Yes. I'm looking at Jo and she's nodding, so I'll give this a go and I'll try to keep still.
So if I move on gently to, oops.
Okay, so some of the strategies that we know work really well for managing these particularly longer term worries, but also short term worries as well. They can be a really helpful tool in the moment. And one of those is, very simple active distraction. So as soon as these worrying thoughts come into your mind, taking immediate sort of steps to distract yourself. And it might sound a little bit simple and unscientific, but actually there's a huge amount of science and evidence supporting these very simple sort of interventions. One example I would always suggest when I was working with particularly the young people, but I think it's really helpful for everyone, is things like counting backwards. So as soon as you start to get a worrying thought in your head, start with a ridiculously big number and try counting backwards in sevens or eights or something quite challenging. And, it sounds quite simple, but what that does is it kind of takes us through that kind of anxiety peak. And we know that's how anxiety works. It comes in peaks. We all feel them. They're very, very like a wave. And if we can distract ourselves to get over that peak and down the other side, we can start to feel our anxiety drop in. And this stops the sort of feeding, it stops reinforcing and feeding into those anxieties and worries. So it might not be counting backwards, it might be something completely different. Taking yourself out of the room, taking yourself into the garden, just doing something physically different. Can just be enough to shift your mind into a slightly different cognitive process or thought process. And there's another really important tool, again, sounds very simple, but has lots and lots of good scientific evidence to support it. So sometimes the simple things really often are the most important and effective, and that's just sitting down and writing. It doesn't have to be to share with anyone. It could be just writing for your own in a journal. We know there's a growing body of evidence now to support the importance of journaling or writing diaries in terms of our emotional health. So using writing can be a helpful process on a day-to-day basis because it helps us get out these sort of feelings or thoughts or worries that we might have. So it can be quite a preventative way of things building up. But we also know emotional writing can be really helpful for processing trauma. So some people might find it helpful to sit down and write the story of their VTE. So sit down, write it down from beginning to end, everything that happened, all your thoughts and feelings at that time. And I've spoken to lots of people who've had thrombosis who did that themselves instinctively and found it really, really helpful. And again, mindfulness is another really important strategy that we can use. We hear about it a lot. I use mindfulness and meditation to help manage my own anxieties. It's something that we can practice on a day-to-day basis. And it isn't that it might think it sounds a bit airy-fairy, but actually there's a growing body of evidence to support this as being a really effective tool that actually has a really important physiological effect as well. So it activates our parasympathetic nervous system. So this really is very protective at a physiological and an emotional level. So there are some really good strategies that we can use to manage some of these worries. Do you want to move the slide on?
Yeah.
For me, Paul?
Oh, sorry, I'm having to do this with me now, so it's not easy. There we go.
Okay, so we just skipped a slide there where we the delay.
No, that's it.
No, okay, sorry. Yeah, so here's just an example that we can share, and I think Joe will be sharing our slides after the webinar. So it's just an example of mindful breathing exercises. You can find lots of these online, and there's some great apps you can download, things like Headspace, Calm. They're all free usually to try. And I really recommend them on a day-to-day basis as a good strategy for heading off those anxieties. Do you want to move on to the next slide?
And Annie's, of course, got her mindfulness classes as well. So, yeah. Okay, so Don't look perturbed. This is what we rehearsed, Rachel. Yeah, so I'm sorry, folks, for whizzing through. I think, yeah, one of the things that I always think of in these longer term worries is that they're often like a habit. Someone's asked about injectables and various other things. And I think habit is, habitual things are typically triggered by external reminders, things like taking medication, things like, at the moment of COVID, I mean, what a nightmare. I mean, everywhere you go, you're just reminded of COVID, and that sets off a whole bundle of worries. And then you get that automatic sort of, oh my God, worry. And I think part of the idea of distraction is to replace that worry with something else. If you just say, I'm not going to think about it, then typically people just continue to worry about it. There's a sort of classic psychological thing, don't think of a pink elephant for the next 2 minutes. And people can't help it, they almost automatically. So it's about replacing it with something else, that number counting or whatever. And I think coming to the slide now, I think that's the important thing, that there's no one way to deal with each of those issues. In a sense, part of the trick of working out what's going to help you is literally trying these things out. Now, it may be that there are some clear ways of dealing with things. So the self-assurance, the breathing is, typically what we use with panic. The mindfulness is typically what we use for worries, etc., etc. But in a sense, it's about working what best for you. Because, for example, people say, oh, I use very positive images. If I'm worried, I think about being on a beach and it sort of makes me feel calm. It does nothing for me because I can't image. I have nothing at all. So for me, physical relaxation, that sort of self-talk, as we would call it, is much more useful. So to some extent, it's worth, trying some of these things out, trying the emotional writing, trying relaxation, and seeing which works for you. Because there is no absolute best for whatever. And if you want a little bit more on these, if you go to the Thrombosis UK website, you have this incredible picture where we've got some simple strategies, as you can see, coping with worries, active distraction, so we talk a bit more about it, meditation and mindfulness, panic, etc., and a bit more on how to relax that we're not really talking about here, particularly at the moment. So a lot of the things we skimmed over, there's more detail actually on the website itself. And then finally, to finish on a more positive note, back to Rachel.
Yeah, I think, one of the things that we talk about a great deal with patients who are managing chronic conditions is that, unfortunately, there is no real magic bullet for solving anxiety, particularly around chronic health conditions or acute health events. But what the research does show us is that actually some of the most effective ways we have of improving our quality of life when we're living and managing these conditions is to really focus on building our resilience, so that when we're better placed to manage these challenges. And what people tell us is that when they have those strengths built on and they feel that they're building their own resilience, then the anxieties seem to slip away a little bit more. So in some respects, it's about focusing on the things you can do to build yourself up to help you cope with the challenges that are inevitable. And some of those things are really simple. Those building blocks at the bottom of that kind of hierarchy of needs, the triangle, making sure you've got enough sleep. Are you hydrated? Are you eating okay? Are you exercising? Are your activity levels good? And of course, you can do anxiety management, like we've talked about, stress management, mindfulness, whatever those things are that work for you. But there's another model which is really, I think, really helpful to engage in. And one of the things that the research shows us is that people who seem to thrive in situations that are challenging do have certain similarities. And some of those similarities are captured here in this PERMA model on the right-hand side. So the P stands for having and introducing positive moments, positive emotions and pleasure into your life, making sure you have good times and enjoyment and pleasure in your life. Engagement, so this is what we mean by being engaged in activities that really fully immerse you. So there's activities that you really get lost in. It's a psychological concept of flow. So those activities where you sort of lose track of time, for example. So it might be music for some people, but for other people it might be sewing, or it might be gardening. So it's finding your thing, as Paul said. Relationships, connections, and they have to be authentic and meaningful connections, not negative and toxic connections. So filling your life as much as you can with those positive connections. And related to that, having a life where you feel connected to a sense of meaning, and where you have a sense of achievement. So for some people, the sense of meaning might be around an organized religion or a sense of something bigger than themselves. And I share this because I think sometimes we can dismiss these things as being a bit airy-fairy and how can they be helpful. But actually, what we know from looking at the literature is that, you know, these are the things, if we incorporate them into our lives, they not only help us feel better, but the evidence is starting to show that they have a positive physiological effect. You know, they cascade healthy emotions and all those healthy chemicals that are protective within us. So we know that they're having a positive effect at a psychological level, but also a physiological level. So sometimes it's not just about managing the anxiety. Sometimes it's about building ourselves up and bringing all this stuff into our lives so that it kind of almost shades the anxiety, makes the anxiety seem smaller. So we wanted to end on resilience because we thought that was a really important area that we wanted to highlight today. But I think that's our final slide, isn't it, Paul? I think we're done, and we've run terribly over our time limit because of said technical issues, which I can only apologise for. But I guess I'll hand back now to Simon.
Well, thank you very much, Paul and Rachel, for what I felt was absolutely excellent talks. And I learned plenty, and I thought I knew a bit about this subject. So we've got about 15 minutes to talk through some questions. And I'm going to take a pick of some that have been sent in advance, and also some which have come up as we've been talking. So I've got one here. Someone has said, it's been almost 10 years since my stroke and 14 years since my VTE. And yet still, every time I get either shortness of breath, a pain in my leg, or God forbid, tinnitus, or sudden pain in my head, my first thought is, oh God, please not again. There is not a day goes by where I don't at some point, if just fleetingly, have something remind me and worry me, especially with my stroke.
I think one of the awful things, we did a survey through Thrombosis UK some years ago, and we were asking about symptoms of PTSD, anxiety and so forth. And we had people that had been experiencing these things for many, many years. So it may come as no consolation at a personal level, but there's a lot of this about. And I think, you know, there is some, it goes back, I think, a little bit to what we were talking about before, that if you do, a lot of these responses become habitual. They're triggered by daily events, and there's an automatic sort of link between that event and now a worrisome thought. And I think this is where sometimes the distraction can come in. And it sounds really sort of, I don't know, mechanical. But essentially, part of the trick is, well, there's two issues to it. Part of the trick is to, every time those thoughts come, don't get sucked in, immediately think of something else. So that may be, it doesn't have to be counting to sevens. It may be talking to someone in a meaningful way so that it takes your concentration. It may be focusing on a task you're doing. But essentially, it is avoiding getting sucked in. So over time, you begin to replace those automatic thoughts of, uh-oh, with a different activity, a different process. And that does take time, and it's not easy because there's a lot of years where that association has been built, but it can be done. I think the second part of this is that if there are things that you have to think through, things that you have to plan that are related to VTE in some way, then choose a time to do that. If you have to plan things to do in the day, choose a time to do it, make sure the plan is made, and then move on, so that you're not constantly thinking, oh, I've got to think about this, oh, I've got to think about that. And it gives you permission then to avoid thinking about it at other times. So then that distraction, that alternative process can be brought into play. It takes concentration. It's not easy, certainly to start with, but it gets easier over time. I don't know if you've got anything to add to that, Rachel?
Yeah, just to mention, you know, meditation and mindfulness again. I mean, the essence of what you're practicing in mindfulness is to live in the very moment. Most of our worries are actually based on things that have happened in the past, or things that we think are going to happen in the future. And I think, you know, how many of us lie awake in bed at night, 3, 4 o'clock in the morning, worrying? You know, so many of us. And actually, what have we got to worry about at 3 or 4 o'clock in the morning? You've got a duvet, you're in a house, it's pretty relaxing. So that's a good example of how it's the thought that is driving the worry, not the kind of reality of what we're in. So mindfulness trains you to observe your thought processes, but not necessarily to have the emotional reaction attached to them. So starting regular meditation or mindfulness practice does start to train your brain in such a way. And I know for me, certainly what that means is I don't react in the same way to some of my worries. I can notice them. I can notice that I'm getting stressed. Look, I'm noticing that thought's popped in my head. I wonder what's bothering me, rather than becoming caught up in the rumination and the worry extensively. So I'm a big advocate of it. And I urge anyone to give it a go, because it does sort of trains your brain in it to be in a healthier way of managing the pressures, really.
Yeah, I think worry in a strange sort of way is a good thing, because it makes you do things. It activates you to sort problems out. But once those problems have been resolved, or when that worry continues to the point that is interfering, then it is a bad thing. So it's a normal response. But it sort of when it begins to take over, that's the time when you need to use mindfulness or these distraction, or both of these sets of strategies. So, yeah.
Thank you, guys. I'm going to go on to another question, which has been by one of our participants. And they've said part of the problem, and sometimes a solution, are the various online forums such as Facebook, Reddit, Quora, which can feed people's anxieties and worst case stories. What can be done to better manage this?
That's a great question, because I think we're bombarded these days, aren't we, with information. You know, COVID's a good example of that. But patient websites and forums sometimes can feed the anxiety, can't they? Definitely. And I think you're not alone in that. So what I will always suggest to people is to almost curate your feed. If you've got Facebook or Instagram or you're on social media, after the forum today, you know, the webinar, go away and get rid of all those things that are feeding your anxieties. I know I certainly do this, and make sure the stuff that I'm being exposed to is going to nourish me and be positive and not feed my anxiety. I think sometimes it's important to be on those forums, so you want to be part of them, but sometimes it's about limiting the time you're on there. Sometimes it's about limiting the time of day you go on there. So maybe be going on last thing at night before bed isn't always helpful. If you read something negative, you're going to lie and do that thing in bed at 3 o'clock in the morning while you're worrying what you said or wrote. And I think sort of counterbalancing it with direct contact with people. So buddying up with someone who may have the same experience as you with VTE. on the phone or meeting up in person when we can do that again. That would be nice, because I think face-to-face contact and support is always going to be better. You haven't got that ambiguity that we get online of how information is given. So I think you have to, there's no easy solution to it, but you have to take control really of the information you're exposing yourself to. I think that's probably the best way to manage that.
Thank you. I'm being mindful of time, so I'd like us to get through as many questions as possible. So another one which I've heard quite frequently, especially because many of my patients use injectable anticoagulants. Continuing VTE treatment, especially injectables, can be a provoking factor for worsening neurosis. How do we address this? So basically, every time we administer our treatment for this condition, it's a reminder each day that we've got it.
Absolutely. And absolutely understandable, because it is, I think it comes back to that it's a trigger to these negative thoughts, to these worrisome thoughts, to etc. So I think it's an inevitable trigger that you can't avoid. So it's learning how to manage that, because clearly if you inject it, you can't just stop. So I think it's about getting into a routine time of when you inject, so that, and as Rachael says, there are activities after that. So you immediately engage in other things that are going to keep you distracted, keep you involved, keep you engaged. So in a sense, it's about managing life around it so that you don't have time to dwell. If the worries come, you engage in other, and it can be difficult. You know, as I said earlier, worry can be a habit, and we're almost designed to worry because it's a useful thing, because it activates us to do things. But when it's not having that purpose anymore, it can be quite difficult to let go. So I think it really is a matter of just making a determined effort and saying, right, as soon as I've done my injection, and to plan what you're going to do, not have the injection and then think, oh, what am I going to do to take my mind off things? It is, right, I'll have my injection and then I'll do X, Y, and Z that will keep me busy, that will keep me engaged or whatever. And, you know, I think I saw somebody talking about reading a book. And the classic is to disengage, you read a book to distract, and you find out that 5 pages in, you've got no idea what the book is about because your worries have been going on and done it. So in a way, it's all about focus. The way you should read a book there is, rather than skim read, it's read it word for word for word until you get into a reading pattern. And I think that's what it's about when you're engaging in these things following, you know, a period of worry. It's not just doing it normally just for the fun. It is doing it strategically to get the benefit from it. So if you engage in a conversation with someone, don't just let it drift while you're thinking. Really think about that, really engage with it, and so on and so forth. So yeah, enough.
Thank you. I'm going to come on to another question, which we've had a couple of questions before this raised, and also we now have had other people online. And it's basically to do with our interaction with healthcare professionals. So, I mean, one short one we had was, my doctor doesn't seem to understand, who could I talk to? And then there's another comment from someone who's tuned in today. After having had a DVT, my own anxieties have been more so triggered by a fear of attending doctor's appointments over concerning symptoms, e.g. leg pain, due to being labelled as just health anxious, or by the way that many GPs or nurses transfer their own alarm over the fact you're taking anticoagulants at a young age to prevent further occurrence. Do you have any advice for health professionals in how to deal with their own transfer of anxiety to patients?
What a great question.
Yeah. And I mean,
I think that
resonates a lot of responses from our friends out there.
Yeah, I think there's so many issues in there, isn't there, about, you know, being somebody, a young person or a younger person on an anticoagulant, how frustrating, I've heard from lots of people, you know, how frustrating that is. They get refused appointments because they assume that they don't need them. What do you need an appointment for? Can't get their prescriptions. The attitude of some health professionals is, you know, it can really fuel anxiety for people.
I think, you know, it's a very real phenomenon, and it's certainly something that, you know, as a health professional, I've seen firsthand. I mean, I think that it needs to be addressed at a number of levels, really, and certainly one of the things that when we train health professionals or we present at conferences or in medical settings, I talk very clearly about the ways in which health professionals should be supporting their patients, and I promote what I describe as a lens approach. So I tell you know, professionals to listen to your patient, empathize with your patient, normalize what's happening for them. And then think with the patient about what strategies they can use. So, you know, part of it's about, you know, us and charities like Thrombosis UK educating health professionals and doing the research to highlight to them, actually your patients are feeling your anxieties, or actually your patients aren't happy with the way this is being managed. So I suppose I'm just sort of reassuring you that we're aware of those things, and that we are trying to engage in that work, for sure.
Can I make a couple of points as well? Just to give you a perspective from the doctor's viewpoint, and this is in no way making it an excuse, but it's just so we can understand it. So if you're a GP, you will have a certain, you know, maybe 15,000 patients that you are responsible for. The number of people who get a DVT or PE is 1 per 1,000 per year. So probably every year your practice, which will have other GPs there as well, may have 15 cases of DVT or PE, and the majority will be fairly what I'd call standard clots, which someone's had an operation, or they've had a chronic illness which has led to them getting a clot. Now, many of the people who will have tuned into this and engage with Thrombosis UK will be people who have been found to have some sort of sticky blood, some syndrome in which their blood produces more stickiness and they're more prone to clots, and they're on anticoagulants lifelong. Some of these people, it will have happened at a very young age, which is not the norm for blood clots, because normally it's a thing that older people get. So we're talking about your conditions being much rarer than the norm. And if what we're seeing in your average population is 1 person per 1,000 gets, for want of a better word, a kind of an uncomplicated standard VTE, those with these thrombophilias or sticky blood, they're going to be much, much rarer. So the GPs will be less familiar with them. Now, what I would hope is if you're someone who's had recurrent clots, or you're someone who's been found to have a condition which needs you to have lifelong anticoagulation, I think you're either hoping that your GP is comfortable managing it. That's the best. The other is, if they're not, that they make sure they get access to it. Now, just looking on the list of attendees, I see names there I recognise, because there are more and more healthcare professionals who are interested in thrombosis. And we are finding, you know, each hospital area now, we are hoping to have someone who is a thrombosis lead, so has a particular interest. And it's trying to make sure that you can get access to them. So the GP makes sure that you are part of that. So if the GP is not as comfortable dealing with the condition, there's someone they can refer to. And that person with an expertise in thrombosis will certainly be able to help more, because this is their bread and butter. So I think there's reasons why doctors don't know it. Also, you sometimes find people get over-investigated because the GP doesn't want to miss something. But as you know, people who've had blood clots in their legs will often get chronic swelling of their legs because the clots cause some damage to the valves. So a natural part of this illness, this condition, is he gets chronic swelling of the legs, and yet swelling of the legs is one of the things that alerts you to the fact the clot has come back. And the only way you know that a clot hasn't come back is if you do a scan. So do you do a scan every time you have swelling, which is every day? So it's kind of knowing as well that you're on the right treatment. So to summarize there, I would say it's trying to get hooked into an expert. Many people we've spoken to have said, oh, I was right in the wilderness, then thank goodness I met Dr. So-and-so, who was a clot expert. I'm just mindful we're running out of time. So I just want maybe to have one more. In fact, rather than having one question, could I just have a summing up, Rachel and Paul? You know, what are the take-home messages you want our friends out there to go home with? I
think for me, the important messages are to know that the anxiety and worry that you're feeling, if or your patients are feeling, is entirely a normal reaction. I think that in itself, reassuring your patients or being reassured that that is a normal reaction to what is a really difficult event, it's a normal reaction. And also to be aware that it's a bit of a journey after you've had a health event like this. And sometimes you can feel like things are getting better, and you can have long periods of being okay with your anxieties, and then something can kick it back up. COVID, for example, can kick up and trigger lots of worries and uncertainty. So, I think it's about normalizing that and understanding and not beating yourself up about that. And secondly, what I would say is to take as much control as you can. I mean, the doctors can know all about the meds, they can give you the best treatment in the world, but there's so much that you can do yourself as a patient in terms of anxiety management, like Paul's talked about. We've got resources that you can access, and there's plenty of other resources in the sort of more generic psychological support or mental health. But other than that, it's about building up your own resilience to sort of almost make the anxiety seem smaller in response to it. And we know from the research that that's what improves people's quality of life the most, is by taking some control of the situation and building up some of the connections and strengths within their life. So they'd be the take-home points that I would want to highlight. I don't know if Paul has any he wants to add to that.
No, I summed it up perfectly. I think it's a little bit like a jigsaw. I think what we're saying is that this is a normal reaction to an abnormal situation, but that doesn't mean that you can not take control and change and modify over time how you deal with it. So, yeah, 100% with you on that.
So I'm going to sum up now. And first thing I want to do is I want to thank Rachel and Paul for taking the time to give their talk, for their expertise. I really don't think you're going to find people around the world who are more knowledgeable or better than you're not going to get better than these guys when it comes to psychological aspects of VTE. So I think we're really very, very fortunate to have them give up their time. I want to thank Jo Jerome, who is not only incredibly organised and helpful, she's really good in helping scatty people like me turn up on time and manage to get on the computers. And so I'm grateful for that. I want to thank all of you guys. This only works if you are engaged, and the comments that are coming through, the number of people participating, has just shown what an important area this is and how much more work needs doing. We do value your feedback. I'm looking at Joe. Do we send out a feedback form to evaluate this? Unmute. Unmute.
I will be sending out an email and asking for feedback. Definitely. And yeah, please feedback, because that's how we progress and continue to deliver what people want. So please do.
I mean, we're doing this for you. We're not doing it for our, for our egos. We're doing it because we genuinely want to try and help and make a difference. And the other thing I'd say is, much of what we've learned about this condition, much of what we've been able to do to help people is because people such as yourselves and people before you have participated in research with us to undertake interviews, to share their stories. Now, if you think that doesn't make a difference, let me just illustrate something to you. I'm involved in some of the clinical guideline writing groups around the world. And 10 years ago, not a single guideline would consider patient experience, patient preference to be important. They wouldn't even consider the psychological effects as an outcome that is worth looking at. They would just look at who has chronic breathlessness, who has chronic swelling of their legs. The world of thrombosis and hemostasis now recognise that the psychological consequences of this condition are as important, are as crippling sometimes as the physical consequences. And we would only have been able to share that story because of patients who participated in these things. With your feedback, let us know what else you'd like to do. If you would like to have another webinar like this or something more focused, let us know. And finally, as a little bit of a plug, for those of you, you know, this has been put on for free. Our time has been given for free, and we're a charity, and that's how we work. We chose deliberately not to ask for money for it. For those of you who do fundraising, those of you who have got some money you want to donate to charity, do consider Thrombosis UK, because actually our money goes into practical things like this. None of our speakers take any money for this. This is too important. We want to get the word out there. But if you do have any charitable funds you wish to donate, you know, please consider us. I'm going to leave it there. Jo, is there anything else you'd like to say before we sign off?
I would just like to reassure everybody that this, within the next day or two, will be available on the website, and I will include it in an email to everyone so that they know exactly where to find it. And also echo what you said, Simon. Thank you to all the attendees. Thank you for feedback in the past, and I hope more to come. And as importantly, thank you so much to Paul, Simon and Rachel for this tremendous session. It's really, really informative. Thank you so much. And the brilliant thing is it will continue to share and to raise awareness and information about this important topic. So thank you so much.
Well,
stay safe, everyone. We look forward to engaging with you again. And thank you for taking part. Thank you for asking your questions. And thank you for your support of Thrombosis UK. Stay safe, everyone. Goodbye.
Thank you.
Thank you. Bye-bye.